There.
Or shot.
Camera.
Plus.
I stepped out there just as I. Number one. I mean, I see the shit on it, but I lost numbers.
New seeds and blueberries.
They're done.
But it just shows like.
Kendra, can you hear us online?
No, we're just giving Walter shit for not introducing you.
Yeah,
Fine.
no, that's all.
Dude, that guy.
Better Walter. Be better.
I'm sorry.
Thank you.
Yeah.
No.
Let's just confuse us. And then I was like, what's
They were just joking. 16 something.
They're going.
Hey, we're in the business. We get.
Tell us the,
Right there. 16.5.
All you hate taking is.
You're adding springs to it, the ladder in the middle.
Air mat, I think it's the air mat.
I don't know how the resistance thing will work.
just see.
The only difference is when you shake this guy's hand, you tell me.
Says the audio.
What?
Says the audio in the room, but.
Come on, Eric. I said it 3 times.
I guess it is.
My friend, so she just got.
Sorry, I couldn't hear you.
On the side.
Your audio is real bad. Your audio.
That's what I said, and my mom said, he is so nice, he will answer. And I said,
So.
bet.
That's a creation too.
His wife.
There's a damn. Reeds. Yes, sir. All right, can I try again? Theron, can you hear us in Oak's room online? I can hear you.
Yes, I can hear you.
Sold out.
And do you, sir?
All right, thank you. All right, we still got about 5 minutes to go, so feel free to talk amongst yourselves. Fill the void.
What?
Not like being watched while you eat.
No, no, I don't.
It makes her tism crash out a little bit.
Yeah, I'll turn the camera on.
She got this.
Show you shoveling food into your face.
No, it was the Tylenol.
David over there.
The only drink while she was. It was the Tylenol.
It happened. Okay.
Yeah, we ran 4 calls yesterday. Yeah, and we slept all night. I met her too.
I saw Rebecca, didn't recognize her.
Did Noah go home last night, or was he out shooting?
Yeah.
Yeah, he went home.
It was built like me. Yeah, like this way stock comes out of that airplane. It's like.
We ran one more. We called after 11. One was going to come around the other one.
Oh, damn.
And we didn't stay in daycare.
That kid is way too loud.
6 months old.
No, I was after.
Still, he's.
Oh, you're right.
He's not getting too many. You gotta go over there.
She got really, really close before.
That's good.
Before I dawned on you.
Yeah,
I mean, I saw the names.
Aaron,
That's really.
Aaron and.
Oh, yeah, yeah.
Yeah, he did all right.
Gonna be on today.
We did busy. Not busy enough though, because he was supposed to press it on the couch.
Aaron did too well.
He did too well.
Oh, the spreadsheet.
I was like, go next minutes. On the scene.
Get off. Like.
Honestly, there should be like criteria.
Well, that's what we used to do, just like 10 minutes on scene.
Stage 4, they were failure.
Oh,
Yeah.
Yeah, I know.
It's not, let's
Aaron just.
let's be kind.
Yeah, tried way too hard.
What do you have as well?
His well, he did.
Actually, ended up killing him.
CPR was excellent. Tube skills were even better.
He was just ahead of me on everything. It's like.
It's like
This got fought.
It's like.
Nice.
For almost 15 minutes. I think we're good.
He's one of them
We
smart.
take off like 3 minutes later, boom.
Give me some breath. Like,
He's like.
smart fuck is Thomas. Collins, that's why.
Yeah.
Yes, Brandon.
I'll point out my imperfections.
My favorite is I get friends, I think, could back the fucking trailer. I get my kids out. All the time up there. It's like,
It was pretty.
It's like, it's like stopping at park, guy, I'm like,
yeah, usually does it.
Oh,
It's that. He's in the pass around, his signs on his face.
Which
Got
made
that
the
last
dog,
night.
like, that's one of the only. She put.
Really?
I think it's. We do charge. She.
Yeah.
She.
I told him it's game. Sorry.
Go to introduction. I'll take some more of that jerky though.
I should. Please.
She has it here.
No, shop.
What?
No, thank you. No, thank you.
So, pass that around for me, please, sir.
Like he.
Did I just say pass that around for me, sir?
Yes.
He's like.
All right, I'm a shit bag.
I'm just shit bag. Daddy, it's shit bag. That's what I shot.
Please, and thank you.
Very first thing, and I wasn't his last day. I wasn't expecting you to see it. It's like,
I'm like, no,
I really felt when it was 7:47, every year something I heard.
So lots of stable. Yeah. So that's just.
This is good. Like they were like, you know, 30. She's just. I heard before you get that lead one and the rest of them. Oh, I mean, you got here. Shove it in your mouth back. Was the one that weighed. So you bring it back up, got it, I had to get the boat to go get it. They asked me how I want them. I just drag out. I was like, okay, so I got a dog gonna die.
Dude.
Ooh, we're doing butterfly this weekend. I have to bring you some on Monday.
You doing?
Yeah, that one's boring. Hell, I don't even.
My favorite part of Walter turns his phone up like he's a deaf old man all the time.
That is sexy.
If you hear it too. I already know it.
Yep.
Ready to go.
Okay, 8:01. We're on to it. Let me just, actually, no, it's being recorded, so online attendance will be recorded as well. How's everybody doing? Still hear us online? Little thumbs up?
I can hear you.
Nice, we got thumbs up. We're good to go. Okay, and can you guys see the gastrointestinal bleeding PowerPoint online as well? Even better. Thank you. I got, Tucker gave us 2 brown thumbs up. All right, so October's case review, I wanted to give it a little Halloween spin. So we went with death and destruction and bleeding. And we've got massive GI bleeding as our topic this month.
Yummy. As a beauty.
As a request came from James for a little bit more of a rapid fire approach today, I have fulfilled his desires. And we're going to be talking about 3 cases actually today, not just a single one. So, but we're still going to use kind of the same structure that we've used over the last couple of months, which is talk about the presentation, the pathophysiology, interventions, treatment, transport decisions, and review for the GI bleeding protocol. Right, so case number 1 was a 74-year-old female who likely had an upper GI bleed. The initial impression was the patient was agitated and very pale. We treated and transported her for the hypoxia and the hypotension that she was suffering from. All right, so our crew on this one, Justin and Brittany, and apologies, I did not clear this week's or this month's case presentation with the actual clinicians on each job. So let's be kind and think of the good things. Don't try to bring up too many sticky subjects here. We had pretty early in the morning job from the looks of it here. just before 1 a.m. We were dispatched very quickly after the call came in, and we were en route really quickly for that time of the morning. And we are at trailer 116 in Kimberly, right? So we've got the QRU from Kimberly with us on this job. And so we've got plenty of hands here. Right, so let's just have a real quick review of our most common signs and symptoms related to upper GI bleed. Obviously, we've got the dark brown stool, right? It's our favorite type of chocolate. Just kidding.
Yeah, man.
Hopefully everybody's finished eating. Oh no, Taylor was not finished eating.
Say
again?
Is there a to log into the meeting?
No, you just joined the Teams link that was sent out. All right, so we've also got the vomiting of blood, also known as hematemesis, right? That can be, bright red blood, or it can also be that coffee ground type substance. And many times it's also a mixture of fecal material and blood, right? When we're talking about, bowel obstructions and things like that. Right, so relevant history for this case, the patient was conscious, very pale, cool and clammy, noted to have several spots of dark, black, runny diarrhea on the bed. Respiratory rate was not doing well. She was pursed lip breathing, had weakness, lethargy, and was bobbing her head, which is kind of a really, really poor sign for this patient's ability to kind of maintain consciousness. QRU was on scene and they put her on 4 liters of oxygen. Something is better than nothing, I guess, with that type of approach. She was also known to have wheezes as well. So we could have multiple things going on here. We could have GI bleed as well as probably some COPD as well kicking in. So we've underlined a few things here. Farther down, she felt sick to her stomach, which is also a very classic sign of some type of GI issue, obviously, but specifically when we're talking about bleeding into the stomach, it's very irritating to the stomach. So you will lots of times get pain associated with bleeding into the abdomen or into the GI tract. She was not able to sit up without assistance. She's weak and dizzy. And further down, we can kind of see that, both Brittany and Justin were required in the back of the ambulance for this job because we actually had Rock Creek Fire driving us in for this job. And she had room air sats of 71%. So not maintaining oxygenation really well. So pretty sick lady here, right? Medical history leads us to think that it could be GI related because she's had GI bleeds in the past, and she's also had ulcerations in the past. Doesn't specifically note that it's a peptic ulcer or, diverticulitis or, some specific known spot for these ulcerations. She was quite agitated, uncooperative, and her GCS was 13. So going to be difficult to manage this patient. Right, she's got enough consciousness to be kind of combative and a problem for getting treatments done, but not helping us out, not unconscious enough to let us do whatever we need to do quickly. Right, I did highlight these medications up here as well, so we're going to do a quick bit of medication review. Ferrous sulfate. Right, generally given to patients with iron deficiency, right? Anemia. So this patient's probably likely had bleeding issues in the past, and she's on iron supplementation to help deal with that problem. Also on ondansetron and pantoprazole. So ondansetron, obviously, we give every day. Pantoprazole is generally given to people with GERD or gastric reflux disease. It's a it types to buffer the acid that's created by the stomach. And a medication a little bit farther down, I want to see if anybody knows what that one is.
That is a
Sulprophate.
sucrafate.
What is that?
It's used for stomach agitation. It can cause ulcers and takes away the lining in your abdomen.
So that medication is used to treat the destruction of the abdominal lining. Yeah. Right. So pantoprazole, sometimes you can hear it referred to as omeprazole as well. It's a proton pump inhibitor, decreases the amount of acid produced in the stomach, right? So you've got these specific cells that sit in the lining of your stomach called parietal cells, and they're the ones that are responsible for helping your stomach create hydrochloric acid, right? What pantoprazole does is it inhibits that production of additional acid, okay? So it's used traditionally to treat GERD, like we talked about, but it's also useful in peptic ulcers, right? So stomach ulcers, and there's a lot of different reasons why people can get stomach ulcers. Lots of alcohol intake, lots of carbonated beverage intake. Helicobacter pylori is another really common cause. That's a bacteria that attacks our stomach wall lining. And something that's really kind of rare, but I've seen a few times in the past 20 years is Zollinger-Ellison syndrome. And Zollinger-Ellison syndrome is a genetic issue that causes hyperreactive parietal cells, right? So they increase stomach acid production. And the last one that might be relevant to our patient here is pantoprazole is commonly used after gastric bypass surgery to assist with healing inside of the GI tract, right? Sucrafate reacts with the hydrochloric acid in the stomach and forms a paste-like material that acts as an acid buffer along the stomach and lower or upper intestinal lining. So it can help in situations where you've got ulcerations anywhere along the GI tract. So it's not just used for peptic ulcers, but it's also commonly used for people with Crohn's disease. That's a tiny little bit of medication review there. Sucralfate. How did you pronounce it?
It's, the other name is sucrafate.
Sucrafate.
Yeah.
Cool. I like that better. It's off the tongue slightly better. It's not a medication that I've seen in a very long time. So,
But they use it here all the time.
okay. Interesting.
The GI doctors here like it.
Nice. Right, so we're sticking with combative and confused, uncooperative. And we've listed this patient as a pretty emergent patient. I would say just based on our GCS alone, you're probably going to be looking at this patient, lethargic, obtunded, combative. We got some serious issues going on here. So let's look at our kind of first set of vital signs. It took a little while to get them. I think a lot of that was related to the fact that the patient was uncooperative here. I didn't highlight it, but I think it's worth talking about. The patient does not have control of her bowels, and she actually defecates during the movement out to the ambulance. It's never a fun time for anybody. She had a non-rebreather mask placed, but she did not tolerate it very well, right? Even with coaching. So the nasal cannula oxygen was bumped up quite aggressively to 15 liters a minute. And we've also got some end-tidal CO2 going on, which is great. Her initial pulse rate, 149, blood pressure 85 on 57. So, when we start to look at the shock index for this patient, we're almost bordering on 2, which is really bad. A very, very ominous presentation for this patient. And even on really high flow oxygen, we're not getting her sats up, right? Respiratory rate is quite high as well. Obviously very distressed. So this is something I found quite interesting. Justin went to attempting a CPAP mask for this patient, right? So remember earlier on in the piece where they had an assessment for lung sounds, this patient had some wheezing and some potential COPD. So if we're not really applying it, I would guess, for, you know, the fact that she's a little bit hypoxic. I think we're applying it more for the fact that she's got lung issues as well here. But we can notice that she is not having any of it, right? These patients are traditionally very difficult to get a mask on. And even though they, you know, tried really coaching, they tried to, you know, help her with the mask, you know, and Justin even had a plan to drop some Versed and maybe look at some sedation here, which is the obvious course if you're really trying to help somebody tolerate a CPAP mask. Certainly could consider ketamine as well, but that's probably a bit aggressive. The other thing that I would be wary on putting CPAP on this patient is you can see that our next blood pressure, right? 64 on 42, okay? Obviously, we all know that CPAP can drop your blood pressure, okay? Increases the thoracic cavity pressure and can restrict blood flow back into the right atria. And so it can drop your pressures quite aggressively in somebody that's really poorly filled. So if I had any type of, you know, advice, if you were planning on doing something very similar in the future, is, you know, if you can get away with, you know, if we can get away with SATs of close to 90 in a patient that may otherwise have COPD or something like that, that's, you know, hampering their breathing, with a pressure that's this low, we'd probably stay away from CPAP for a little bit, right? You could certainly, if the patient was uptunded enough, you could certainly try to track their respirations with a BVM without a PEEP valve on it to try to give them a little bit more volume. But instilling PEEP on some of these patients is a really dangerous component. So really high respiratory rate. We still have a really high pulse rate here of 150. And so we've gone with a nice size fluid bolus for this patient, 500 fluid bolus. That's obviously the right thing to do here. Getting a really good correction in the blood pressure after we've started to give some fluid. We're trying CPAP still again after our blood pressures have gone up, but it's just not, you know, really being tolerated much by the patient. And Justin's done the right thing here. You know, he's really thought about the Versed and just gone, blood pressures are too low, the heart rate's too high. This is just not a good, it's just not a good fit for this patient. So he's fallen back to nasal cannula, high flow oxygen here, which I think is definitely the right call for this patient. We can see that we're starting to get a CO2 trace here, right? But it's pretty bad, right? 7, 6. That's what we many times see in cardiac arrest patients. Okay, so this patient is really, really shocked.
That's what Webster would say.
But as we kind of go through the job, we're making progress here. We're making quite a bit of progress. Our respiratory rate's coming down. Our blood pressure is trending up. Pulse rate is trending down, which is what we want. Our shock index here, about 20 minutes later, is looking a significant amount better, right? Pulse of 120 and a blood pressure of, 110, round up.
If she had more red blood cells, her end-tidal would be higher.
Exactly right. Yeah.
Yeah. Transfusion.
Right, so let's look at the patient follow-up for this patient and kind of discuss why we think the patient had the GI bleed in the first place. All right, so we can kind of see down here on the bottom, date unknown, that the patient has had a previous gastric bypass surgery. Okay, the fact that it's date unknown would lead me to think that it was probably a while ago.
Back in the day.
And the revision.
Yeah, so the day that we've brought her in
Mexico.
is on the 17th, which is what I've highlighted over here. But she was in for a GI consultation on the 9th, and they did a duodenoscopy, which is, looking for some type of issue going on in the GI tract. So she probably had a GI bleed prior to, the 9th, and she's probably bleeding over the course of weeks and or maybe months, just trickling it in, likely from some type of issue going on. We can see on the 20th that they brought her back in for surgery, and they repaired a gastric fistula. Okay, so gastric fistulas are really common after abdominal surgery, especially things like gastric bypass surgery. And that's essentially where an ulcer inside of the stomach doesn't heal, and it creates a tract out of the stomach and into the abdominal wall, sometimes all the way back, all the way through the skin, right? Which is a really kind of ominous finding, and that's likely the major cause of our bleeding there. She's gone back in on the 20th as well and done a revision gastric bypass. So they've gone back in and had to revise the previous gastric bypass that she's had. So this is probably why, when we're looking at this patient, why she was so decompensated. And I didn't actually see her lab values. I had to look for them, but I couldn't find the actual lab values for her, for all of her blood markers. But if we're going to guess, her hemoglobin and hematocrit are in really bad place. Okay. So that's a classic upper GI bleed, right? So this is what we're kind of talking about with a fistula. This is obviously a pretty aggressive photo. It doesn't actually look like this, but what happens is you get that erosion of the lining of the gastrointestinal tract, and then you get this movement and or bleeding because it's going through all the walls of the lining. And so you're just getting, capillary blood generally leaking back into the gastric tract. And you get some localized irritation as well, which is what we saw. She had a lot of abdominal pain. Right, so do we have Brittany or Justin online? We have Brittany. How are you, Brittany?
I'm good, thank you.
Good. So can you give us any insight to this job? How it went, how the patient looked? She looks pretty bad on paper.
Yeah, she looked really bad, and she was back inside this little tiny bedroom. And yeah, you weren't kidding. She, when they went to carry her under the stair chair because we couldn't fit anything back there, yeah, she definitely defecated, and it was black. It looked like the color of your boots. And she was just super combative with us, not cooperative at all. We were trying the CPAP on her, and we just kind of had to hold it just kind of next to her chin as much as she would tolerate the CPAP. And on top of that, we had the high flow nasal cannula just to give her as much oxygenation as we could. So I don't know if that had an effect on the CO2 reading, is why it was so low. But yeah, she just was not cooperative, and we're just trying to do the best we could because we couldn't use any type of sedation, considering her vitals. So yeah, it was not pretty. She was not doing well, but yeah.
Nice. That's a good point. Thanks for bringing that up. I did not catch that part. So she probably had a much better end tidal CO2 than 9, 10, whatever it actually was, right? She's probably getting a lot of that CO2 washed out. So without actually seeing the waveform of that CO2, it's probably hard to judge whether or not it was accurate. But we would certainly potentially see fairly low CO2 on a patient like this because they just can't move gas around very well inside of their body because they don't have the blood cells and the blood volume to do it. So anything that you think on the job could have gone better, Brittany? You're pretty happy with how Rock Creek helped you guys out on that job and everything?
Yeah, no, Rock Creek did really well. They're the ones that, were pretty well the muscle that carried her. One of the Rock Creek guys and Justin were the ones that carried her under the stair chair. And he's actually the one that took the majority of the blunt of the defecation onto his boot. So props to him. So props to Tyler on that. But no, they were they were really good and prompt about just being there, and we just kind of got rolling quite quickly. We just had them drive, and while we just worked around the way in, and so no, it went actually as well as it could have gone. So considering how, like I said, how combative and uncooperative that she was with us, so we just had to constantly keep coaching her and trying to calm her down, and so it went pretty good, considering.
Yeah. Well, thank you very much for your input.
You're welcome.
All right, that takes us to case number 2. Got an 84-year-old male patient with a GI bleed. He's got known hemorrhoids. The initial impression was kind of not really too descriptive. So the main thing that we treated him for was a bit of acidemia. And we took the patient to Magic Valley. So this patient was in much better health than our previous patient. So I thought I'd go really sick, not so sick, kind of as a bit of a change of pace here. So we've got Jas and we've got Lindsay on this case. We've got called at about 9 p.m. and we were en route very quickly. Nice job, ladies. At the patient within about 7 minutes and at destination. Took us a little while to get the patient out, situated, and over to the hospital. Right, so looking at this patient, he was sitting on the toilet. Generally not another good sign, but as we do with the GI bleeds, it's usually not the nicest jobs that we run. His son was on scene, and his ability to answer questions was good. The patient's area was patent, was breathing normal, skins look good, right? No blood or emesis is noted, so he's not vomiting up any blood. That's great. So our history here is dark stools with rectal bleeding, all right? Patients had dark stools for several days, and about 15 minutes ago, he passed a very large clot into the toilet. So we know that he's actively bleeding here. Both dark tarry stools, which is going to indicate that the blood is actually being digested, right? It's spending a lot of time in the GI tract. It's not frank red blood coming out in the toilet, but he's also got a very large clot, which signifies that he has some frank red blood as well. So he's got a mixture of red blood and also blood that is being digested. So this gentleman is probably bleeding from multiple places inside of his GI tract, right? The patient denied abdominal pain, but he said he's dizzy and short of breath. Right, so his GCS is 15, that's great. His breathing is at a normal rate. His cap refill looks good. Nothing too crazy going on with this patient. He's looking rather well considering the fact that he's got a couple different GI bleeds going on. Okay, he's oriented like we talked about. We've given him some oxygen, some IV fluids, right? Helping him out with that shortness of breath, helping him out with that acidemia because he's probably got a lack of red blood cells that's able to carry oxygen around his body, right? So we can see initially we've got a shocked patient here still, right? We have a shock index over 1, which is not a great look, right? Got a patient who is looking pale. His vital signs are leading us to think that he's just compensating at this point. Okay, he's dizzy like we talked about before, another good sign that he's probably suffering from compensated shock. We've got an IV into him, nice work. And successful on the first attempt. Okay, I think our next set of vital signs may be a bit erroneous with the blood pressure there.
Why don't just delete those ones?
It's a good question. It's a good question. That's okay. We're here to talk about things. So what's the consensus amongst the room? Do we usually, when we get a reading like this, do we put it in and make a note underneath it that query, we've got a set of vital signs that might not be accurate?
Not if you have one.
Well, you can see that they recycled that. I wouldn't even add that into the chart.
Yeah.
Likely.
Okay,
Yeah, I
And-
accidentally clicked that one in there.
that's okay, Lindsay, that's all right. We're here to learn and thank you for putting your hand up and saying that was an accident. That's a great job.
Yeah, no.
So, yeah, so as long as we have a consensus that, most of the time what we're doing is probably not including vital signs that we think are probably erroneous in the chart. But like you said, good job. You've recycled that set of vital signs straight away. And that's why I've not highlighted that one at all here. But, right, so we've come back, the patient's blood pressure is looking considerably better, right? A lot of that might have to do with position. Our heart rate's also looking a lot better at this point. We've got some fluid going into the patient, which is an obvious good thing for this gentleman because originally our shock index was looking pretty poor. Okay, and we made the notifications off to the hospital and transported him successfully. All right, so let's talk about patient follow-up for this one. Right, as many GI bleeds go, it can be pretty hard to find where patients are bleeding from, right? So we've got an unspecified gastrointestinal hemorrhage after a look from the top, okay, which is what we can see they've done on the 17th. They've gone down through the top end to have a look at the upper GI tract. They've gone back in on the 18th and done a colonoscopy to look for bleeding from the bottom end, right? And we are unable to really find where this patient was bleeding from. So this is very common, and I've done a lot of theater placements, and I've seen a lot of GI surgeons go hunting for a bleed somewhere in the gastrointestinal tract. This elderly gentleman on blood thinners, okay? Many times these patients will have a bleed. The bleed will go away for a few days. It'll come back the next week. It'll heal up again to the point where it's not bleeding, and then it'll come back a month later, right? This is a really common problem in our elderly patients that are on blood thinners. Okay, and that's why, they've gotten away from doing a lot of, historically, probably over the last 20 years, they were putting patients on 325 of aspirin every day for query, blocking the clotting cascade for patients so that they weren't having, strokes and they weren't having heart attacks. But what we saw a lot of times with those patients is the risk for GI bleed was too high. And many, many of those patients ended up having GI bleeds and ending up like this gentleman here in theater and having somebody stick a camera down and up both ends looking for this GI bleed that they just can't find, right? So we can see here, we found some pertinent lab findings. The hemoglobin was originally at 7, right, which is pretty darn low. That's about where you want it. That's about half where you want it. That's right, Max. So, and in an elderly person, their hemoglobin does go down a bit, and that's quite normal. So somewhere around 10 to 12 wouldn't be too abnormal for somebody 84 years old. But 7 is really something that's quite dangerous. And that's what we saw, the patient expressing dizziness, shortness of breath, right? Likely due to the fact that he doesn't have enough red blood cells, okay? He had a transfusion and his hemoglobin rose to 8.3, indicating a partial improvement. And the biggest problem for this gentleman when Jas and Lindsay brought him in was he had an acute metabolic acidosis. So somebody talked to me about why you think they would have a metabolic acidosis when they had a GI bleed.
I think the biggest reason is there's not enough blood to like actually do the full breathing, oxygenating and deoxygenating cycle. So it's just, there's not enough hemoglobin to carry that around through the body.
Yeah.
So you get a lot of like stagnant hypoxia because the blood essentially is cooling because there's not enough of it moving.
Yeah, that's certainly a component of it, yeah.
It's also extremely difficult on your kidneys to digest blood. And obviously your kidneys are very important for carbonates.
True. So, I mean, the biggest reason why patients have acute metabolic acidosis with a low hemoglobin is you look at how your cells, and it goes all the way back to the cellular level, right? You have anaerobic and aerobic respiration or metabolism happening in the body. Without oxygen, we end up in anaerobic metabolism, which creates a lot more lactic acidosis. We can't clear that lactic acidosis through the normal processes. And so we end up with an acute metabolic acidosis, right? That's probably the number one reason. So both of you guys are totally correct. And those are certainly big components of it. But when we see somebody who we think has a significant deficit in red blood cells, okay, what Jas and what Lindsay did here by giving the patient some fluid is absolutely the right call, okay? Because what we want to do is we want to help those kidneys get rid of that excess acid. And we also want to provide a good level of blood pressure so that all of our small capillaries actually have enough pressure to get fluid around them and move that lactic acidosis out. So if we have a low blood pressure, our capillaries are fairly low volume blood vessels, and we're not actually shifting that cellular waste out to the kidneys, out to the liver, up to the lungs to get breathed off as CO2, right? So real quick look at the GI bleed protocol for us. It's a pretty short and succinct protocol, but I thought I'd just bring it up since we're talking about it. Both cases that we can see, we've gotten oxygen onto the patient. If you've got a deficit of red blood cells, it's a good idea to saturate those red blood cells that we have with oxygen, right? Because we need them to work a little bit of overtime for us. Again, though, what we want to do is we want to make sure that we don't have too much saturation of free floating oxygen in the bloodstream. And anybody that went to the vent training last week with Eric Kessler, he talked about that briefly. He talked about super saturating the blood with oxygen. And what that does is it increases free radical production, actually bad for the body. So even though we've got patients that are not looking well, we still don't want to drive their SATs up to 100 for extended periods of time, right? Because that will actually worsen acidosis in many cases. We want to treat those signs of shock. Both of these patients were shocked. The first one was really shocked and looking quite terrible. And our second patient had, signs of compensation, but his heart rate was still quite high for an 84-year-old. Ticking away at over 100 beats a minute is quite a good clip, right? So if we ever get packed red blood cells here for Magic Valley, we can consider giving these patients some blood products, right? I would say that in most cases, most of these patients do pretty well. But if I was looking between the two patients that we had prior, I would say that Justin's case would probably be indicated for some use of packed red blood cells here. We had a really low blood pressure. We had a really low oxygen saturation. And we know that the patient's bleeding. They have dark tarry stools, a history of GI bleeding that's been recently chased in hospital, right? I would say that that patient is certainly indicated for blood products, okay? I think we look at blood products many times as a trauma or nothing type of situation. If there's not red stuff on the ground, we don't give more red stuff, but really this is one of the patients that takes the vast majority of blood products from the hospital system, okay? So if we can give it to him early, that'd be great. The other thing that we discuss here is placing a nasogastric or orogastric tube. Okay. I would think for both of our previous patients that that's probably not indicated. But we'll look at our next patient here and maybe have a consideration for it. But at the same time, if we're suspecting esophageal varices, that's highly dangerous. Okay, so we definitely don't want to be placing. I know we're not placing a whole lot of naso or gastric tubes in the service. We have them available to us. I'd like to see us using those a little bit more often. Okay. Classically, this is a really good patient population to use a naso or a gastric tube on, but traditionally it's more for your GI bleeds with a bowel obstruction, right? Where I don't want to end up with fecal vomit in the back of my ambulance on a transfer from Wood River to Boise, okay, or from, or from Twin to Utah, wherever we're going. And especially in the flight environment, now that Cassie's here and that Max and Andreas are going through light, I would not fly patients with bowel obstructions unless they had a nasal or a gastric tube in place, okay? Sometimes it helps, sometimes it doesn't. We don't have proton pump inhibitors with us currently, but it's certainly something that you could consider if you're doing an interfacility transfer and the patient has not received those yet for some reason. Okay, so think about your interfacility transfers here as well, not just the one call. All right, any comments there, Lindsay, Jas? Good job on that case. Anything interesting that you want to share?
Not really. It
Not
was
really.
pretty cut and dry.
Oh, good. I was just gonna say that.
Good job. Sorry I didn't let you know beforehand, but good job.
Thank you.
All right, case number 3. 49-year-old female, GI bleed, in cardiac arrest. The initial impression was she was dead on arrival. This was Ken's job, Garrett Haldeman. Noah. Yeah. Were you on this, Aaron? Yeah.
I was the pressure bag pull. I turned into a cop.
Nice.
Disappeared. Watch them work.
Let Noah get right into the action.
Yep.
How was the young man's Is Noah online? Noah's online today, isn't he?
Yep.
Good morning.
Good morning, sir. Get to do some CPR on that job, Noah?
I surely did. I turned into a cop or a firefighter, if you will.
Nice work. Right, so, let's see. Oh,
Tamarine.
we've got the dream team. Ken, Aaron, Noah, and Garrett. Right, so we got a 49-year-old female patient. So pretty young for cardiac arrest, obviously. We've got this pretty early in the morning from the looks of it. The dispatch and en route, good time, really good time, under a minute. At the patient about 6 minutes after dispatch, 7 minutes after dispatch. So we're in that 10-minute window, which is great. And there was some on-scene bystander CPR for this patient. So that's going to extend that 10-minute window for us a little bit, hopefully.
25 to 1.
25 to 1. Close enough.
Yeah.
Push hard and push fast is all I think they say and on the dispatch now, isn't it? Just push hard and push fast. They don't even bother saying breathe.
Yeah,
for it.
it's just, they said he's gonna.
We're in Twin Falls here, and obviously we got Twin Falls Fire in assistance with us. I believe, yeah, Twin Falls Fire. Right, so relevant history, medic 1 dispatched the patient. Patient was on the living room floor. Twin Falls Fire is ventilating the patient and performing CPR. So originally it was called in as a female breathing, very shallow. right? So we probably just got agonal breathing here at this point on the dispatch. Okay, the patient's husband states the patient had been dizzy and been passing out when she stood up. She had vomited up blood today. And he reports that the patient is an alcoholic and has stage 4 liver failure. So we talked briefly about this, we knew kind of looking at this patient, this is probably a fairly futile resuscitation, given the patient has stage 4 liver failure. But until we can really, determine whether or not the patient's going to be a survivable patient, we still have to work the cardiac arrest in these cases, especially at 49. Right, so the cardiac arrest was witnessed by a family member. Was that the information that was given? It was a witnessed cardiac arrest, or that he didn't?
Kind of, sorta. Yeah, she was in the living room, hadn't been feeling good. He walked back in the bedroom, saw her like 15, 20 minutes prior, and then he came back out. He said that she was kind of like doing this weird panting type thing. And then he came back out, and she was down on the floor. Saying that she was agonal respirations because he said that she was still breathing.
Yeah.
Stopped, and then he started. It's 25.
Yeah. So, really, we do probably have, as far as witness arrests go, this is probably a fairly good one, right? The patient was seen pretty soon, or pretty shortly prior to going into cardiac arrest and breathing. So that's a good indication that we have a workable arrest. Right. We know she's got a significant GI bleed, as we'll see a little bit later on in the case described. And we're doing all the things that we normally do on a PEA arrest. The patient was in a PEA, not an asystole or a VF, right? Which also indicates that it's potentially, what we call a low flow arrest, right? Or a hypovolemic arrest, all right? So at 46, CPR was initiated prior to EMS arrival. Good CPR from Twin Falls on this job. Nice to see. Okay, we're ventilating them using a BBM. If you had to grade BBM usage by Twin Falls Fire, see, pretty good BBM usage. Yep. They weren't bagging the heck out of the patient at 20 breaths a minute.
No,
They were sticking to their 30 to 2. Nice. I'm not 100% sure, but do any of the Twin Falls guys have option modules for supraglottics? Do they carry supraglottics?
No.
No, they don't. Oh, okay. Is there an obstruction to them carrying supraglottics like Ogden's?
Yeah, can we talk about that after the meeting?
We can, yeah,
Okay.
absolutely. I like to learn a little bit more about the capabilities. I know it's, if you get your options module, supraglottic is good. And it's a lot safer for the patient.
Yeah.
Right, to have a supraglottic in place.
Good Dr. Burris discussion.
Yeah. So who oversees them as their medical? Burris does. Right, so we've arrived on scene. There's good CPR. There's good BVM work going on. Right, so that's going to lead us even more into thinking that this patient is probably a viable cardiac arrest patient. Right. Monitors pre-charged, the patient's in PEA, CPR is resumed. Does anybody remember what type of PEA? What's the rate? What's the quality of the rhythm look like? Garrett online? I don't see Garrett online. No. No, do you remember what the ECG looked like? If it was a fast PEA or a slow PEA?
It was like
Fairly slow then, fairly agonal looking. Yep. Really that rhythm of the PEA has a lot to do with the viability of the patient, right? So when we start to look at PEA arrests, there's a huge range of PEA arrests, right? So if you've got a real agonal, quad, terrible looking rhythm, that's a PEA that's been in a PEA for a while probably, right? And the heart is just slowly shutting itself down. We can almost, and we don't have the information at hand, but we can almost kind of guarantee this patient was probably tachycardic before she died for some time, and then slowly started to decompensate, okay? Every once in a while, when you get to a PEA arrest, that rhythm might look nice, it might look organized, it might have a good rate to it. And that's a pretty viable patient in most cases, right? So if you're going to be looking at grading where you're at with a PEA arrest, as far as if you're thinking that you're going to get ROSC pretty soon, or you're thinking that it's going to degenerate into an asystole or a VF, have a look at that rate, have a look at the quality of the rhythm underneath that PEA, and just kind of try to plan for it a little bit. Okay, IO, by Ken. We got distal tibia IO.
The wall time.
Oh, sorry. It says distal. Did you go distal or proximal? Proximal. Okay. Are we ever placing distal tibia IOs?
No, I think it gets misplaced a lot of time.
Shawver and I did one on a code.
Where in the
There's a.
It's a possible site, you can definitely use it. Obviously, if we're looking for kind of higher flows, the proximal tibia is probably the place to go. I don't think we've talked about it too much about IOs and about how we get fluid through an IO. What's the normal practice here for when you establish an IO? Walk me through, after the needle goes in, what are you guys doing to make your IOs work for you?
Trying to get the heart.
Yeah.
Push, just do a really hard flush, so it's a cavity in there.
Yep.
But yeah, aspirate. Through a lot of times you get. And then shove it. Pretty good.
Yep. And then after you flush your IO and you're hooking it up to fluid, is there anything else you guys are doing after you hook it up to fluid? Pressure back.
And if the patient's awake, then they use.
Yep. And copious amounts of ketamine.
But in this case, we wouldn't use anything.
Yeah. Yeah, so that's good. I think, the way that I was taught to do IOs, back in the day, we didn't include the big flush in it. But if you want your IO to run at a fairly fast rate, that flush is a really important component of it. I kind of went to, because I had larger syringes where I was working before, I went to a 50 mil flush. Yeah, and I saw the rate of infusion go up significantly after a really large flush like that, right? Instead of like a 10 mil flush. So if I was going to have to make a recommendation as an educator, and I haven't worked with you guys on the road yet, it would be to flush it significantly, right? 20 mil probably at the least will really improve your flow rates on an IO. Not as big of a deal with humeral head IOs. Humeral head IOs seem to run pretty rapidly when they're attached to a pressure bag, but tibial placements are kind of, they're kind of famous for having fairly low flow rates into the tibia, right? And for a patient like this, who's in a hypovolemic arrest, likely, if we can get a leader into them, which you guys have done really rapidly here, that's a great thing to do. The other thing you can certainly do if you're not getting a great flow rate, even with a pressure bag attached, is you can supplement that infusion rate by the use of a syringe, by actually pushing it in faster, okay? The only thing that you might have happen to you, and I have seen this done personally myself, is you might end up pushing your IO out because you're pushing too much fluid in rapidly, and it'll actually push the IO out because of back pressure inside of that bone space. Remember, the bone's not going to move in a 49-year-old. But that's even more important with a really small child with really gummy bones. So it's very difficult to keep an IO in a small child who has a gummy bone, right? They come out really, really easily. And so just be aware that if you're going to be trying to push fluid in more rapidly, that actually happen every once in a while. So are we almost always using the IO securement device that goes on top?
If we have it,
Yep. That's a really important component to have.
they're constantly out of stock. We get them and then everybody loads up and then they're not stored.
That's a really great way to keep your IO in place. You know, when I was running around on a fast response car doing like 2 or 3 cardiac arrests a day sometimes with the geezer squeezer.
Yes.
The big thing that I learned with the IOs was that they get knocked out quite easily without that securement device, or pulled out or bumped or, you know, just wiggled around, and then you get fluid boiling up under the skin underneath. Okay. Which is obviously not a great look when we drop the patients off. So if you can secure those IOs and give them a really good sized flush, that's going to increase your capability with those many times. We've gone in straight with a really nice large bolus of fluid. Okay. Again, if we had blood products here, we'd probably be replacing like for like. Yeah, we have a good suspicion that this patient was bleeding to death. Was there blood coming out of her airway from the get-go?
Yeah.
Yeah.
Yeah. It's like a faucet.
The
Yeah.
Joker smile going.
Yeah.
Where
So-
are we getting blood from the supervisor?
We're a long ways away from getting blood still.
No, on the supervisor.
Yeah, a long way away.
You can't have us working S1, 6, and 7 and have us have blood.
Not on
I
there.
heard that. There's no way we can do it.
Okay.
Yeah, it's
I
gonna be-
remember we had a
gonna be
conversation
difficult.
about it.
But there's a lot of administrative burden with blood product, so we'll have to build that process up over time.
Blood that expires.
And then as well, we've got to look at the usage rate and everything else for it to make sense, because it's to the health system, a blood program, you know, of this size would probably cost somewhere around $1 million there.
I swear I heard a conversation about adding something on the truck. Maybe like something else like tax, I don't remember.
Yeah, pack red cells are a little bit less expensive, obviously. But you're still gonna probably be somewhere around the $500,000 mark to set up and maintain and everything else. They are not cheap, you know. Like each bag of blood is probably somewhere around $1,500,
Jesus Christ.
you know, 2,000 sometimes.
You should all donate.
As soon as one of them goes bad, they be all.
Yeah, your wastage rate is usually somewhere around 5 to 2%, something like that, but anything above that, you start to run into issues. So we're maintaining a PEA arrest throughout the trajectory of this patient, which is really great. That means we're still doing good CPR. We're trying to get the patient back here. We've got the fluid going wide open and the pressure bag, like we said, is getting used. We're going with epi like we normally do in cardiac arrest. We've got Garrett doing a great job here with intubation. Okay. This is going to be a very difficult patient to intubate because we got blood coming out of the airway kind of straight away. And Ken was very surprised that Garrett got the tube and slotted the tube in this instance. As we can see later on, Ken goes back in and has another look, and it's an absolute bloodbath in the back of this patient's airway. So well done to Garrett here. We've got a grade 2 stylet inside of the tube. We've got a 7.0 secured 22 at the teeth. We've got manometer at 30, which is perfect. Garrett's used a Mac 4 video or direct. I didn't see that necessarily in here, video versus direct.
Hope he didn't go back. It's too close.
Using the solid method. I'm not familiar with the solid method.
Solid, it's.
Salad.
A salad.
He uses voice to.
Okay.
Write
All right.
some things, so it gets.
I was like, I do know about salad, but I don't know about solid. But he's placed this tube solidly into the patient's airway. And Garrett and I actually talked about this tube a little bit. This was a really challenging intubation. He could see the arytenoid cartilage for this patient and the very bottom of the glottic opening. But not much more than that. Okay, which is very common in a patient who's laying flat on their back with CPR going on. Okay, we don't have the capability to ramp these patients many times, but we do have the ability to lift their head slightly. Did you see the intubation?
I was at the feet. I didn't actually see him past the tube.
Yeah.
But,
Aaron, did you see Garrett
wasn't
intubate the patient?
Casillas was up there with.
Yeah,
him.
Casillas
He
was
said
there.
that, he said that he saw
Joe, she is the firefighter
some
from Land.
landmarks.
Oh, Joe.
Yeah.
Yeah.
He
So-
just finished his round of CPR and was getting ready to circle back through.
Yeah.
Or cycle back through. I was helping Kenny with meds and.
Yeah.
Holding him heavy back.
And it was the video scope that got used.
Yeah.
Yeah.
So basically, make them look at forward.
Yes. So, job well done to Garrett on this. This is a really difficult tube, and for a new medic, he's done a great job. So we've continued with the epi here. And after the tube placement, we're getting our first end tidal CO2 back. And tell me about what you think about that end tidal CO2 number.
Good CPR.
Good CPR. Great. What else?
Jump is a good indicator that you got.
Sorry, Stormy, you're whispering.
Sorry, the jump from the 24 to the 40 is a pretty good indicator that you have better cardiac function.
That was about the time I let the Kenny say, don't say nothing again. Your pulse is back.
Yeah, so 26 is a really good, that's great CPR. We know we've got good perfusion to the lungs because we're exchanging a good amount of gas. Once we start looking at CO2s less than 10, I know that probably everybody in this room knows this, but CO2 less than 10 is a very ominous sign for a cardiac arrest patient. Being that this patient was probably a witness arrest and had a very short downtime, good quality CPR, even some mediocre to poor CPR, but it's still going to be pushing some blood around prior to Twin Falls fire arrival. Okay. We've got good perfusion here. Okay. This is a viable patient. Not necessarily from the patient's history perspective with stage 4 liver failure, but from a numbers perspective and from looking at this case from the outside in a PEA, this is a really valuable cardiac arrest, because we might get this one back. Right. And that's obviously what happened. Ken was about ready to go and have a chat with the family.
Finished talking.
Okay. And had talked to the family to prepare them for the eventuality of a termination here. Which, we want to have that conversation early on, right? And there's no point in delaying a conversation with a patient's family saying that, we're trying our best. We hope that they come back, right? There's a lot of value in telling the family very early on in the piece. Out of hospital cardiac arrest is generally not a survivable situation, but we are trying our best to help this person, right? And you don't have to say that the person is not viable anymore, or that what you're doing is pointless. But it's good to have those conversations with the family very early on in the piece, usually just prior to you stopping CPR on a patient. Because if you stop CPR and start packing up and then go and have the conversation with the family, a lot of times that's their whole emotional train is riding on the fact that you're still doing something. And when you just stop, they collapse, right? And that's really not a nice way to end a resuscitation. So thank you, Ken, for going and having the discussion. You know, we know the outcome for this patient is probably going to be pretty poor based upon her medical history, but it doesn't change the fact that, you know, we're trying our very best here, and trying our very best gets us back carotid and femoral pulses, right? So, you know, we've been in cardiac arrest here. Let's just have a quick look at the times. So from 46, when we arrived, 20 minutes of CPR, and we've gotten Roscoe. So we were right on schedule, really. It's the pull the bicarb out in the last round of CPR and push the bicarb scenario. And we've got the patient back, okay? Right, so let's have a quick look at the salad technique here. Explained to us by Jim DeCanto himself.
Let's go again.
Right, so let's deconstruct the salad maneuver real quick. I find that Dr. DeCanto speaks very quickly. It's hard for me to follow some of that video, but in a patient like this, where you've got a lot of blood in the airway, this is a really valuable kind of technique to have, I would say familiarized or, maybe even mastered if you're intubating a lot of patients. So I find specifically that we've obviously got a lot more hands available to us than what you can see here in this video. They obviously didn't want to crowd the lens. So you've got more hands available to you. And I like specifically using an airway assistant to do a lot of suctioning for me, okay? Because they have better tip control of that suction device. So instead of just parking it off to that left-hand side and leaving it for myself to control, which now I have pretty poor control over, I'll actually ask somebody to come up and control it via the video, right? They can see the video. It's right in front of their face. It's right in front of my face. If you see stuff coming out, I need you to be in there sweeping around and getting it out for me, okay?
I'll go to my lab.
Say again?
Being racist.
So use your airway assistants in these cases if you have them available to you. I know that, traditionally, bougie is not getting used a whole lot in our service. Most people still like the stylet situation, but a bougie really does afford you some flexibility in an airway that you can't see the glottic opening on. So have a consideration if you're doing some airways into the future to try to, just try to familiarize yourself with the bougie a little bit, with the bougie, the only thing is many times is you'll need somebody assisting you again to push the tube over the top of the bougie, right? I like the way that he explains the major problem with the bougie is holdup of the tube on the arytenoid cartilage inside of the airway, and the way to get around it is to just spin it, okay? It doesn't really matter whether you spin it clockwise or counterclockwise in my experience. As long as you're spinning and swiveling the tube as it's going past those arytenoid cartilage, you don't generally get the hang up involved with it. So that's the salad technique in a nutshell. Has anybody ever used the salad technique?
Kind of modified.
Yep. What was the modification?
Well, I didn't start on the right, go left. I just held it next to the laryngoscope as I went. So like suction on the way and left it there and then just put the laryngoscope in next to it. I feel like less is more when you're not moving from one side to the other. There's less room for like mess up. Why take it out if it's actually currently suctioning and doing its job?
Yeah. Okay. Yeah. I mean, I'm a real big fan of having the bougie in my hand while I'm putting the laryngoscope in, because I want to get that tube in as quick as I possibly can. So if you've got an airway assistant, or you're using that technique where you're talking about where you're holding the actual suction decanto in your hand and the laryngoscope at the same time, as the laryngoscope tips coming down, you're suctioning everything that you can see with it right there, right? So you're clearing as you go, which is a really good approach to getting a tube in fast, versus traditionally that right hand, left hand suction. Now I'm in the back of the airway for 15, 20 seconds before I can clear it out. And now I'm grabbing my tube. Sometimes I take my eyes away from the airway. Okay. Which is, I've heard Dr. Burtis say that now on successive paramedic final simulations, that he'd like to see us not taking our eyes off of the airway once we're visualizing it. Right. And that's about using your either prepared method like you have yourself, or it's about having an assistant there that can see what you're doing now because we have video, and they're helping you decontaminate the airway as you're putting a tube in. So very good. Any questions about the salad technique or any? No? Good.
I feel like he stuffed the bougie down awful far to me.
Yeah. Yeah, and the reason that you want to push the bougie down a considerable way is because if you're leveraging your tube placement off of the bougie, okay, if you've only put yay much, couple centimeters of bougie in, when you start to push the tube down in the oral pharynx, what happens sometimes is the bougie will slip out. They'll just, if you're playing just the tip, it just comes out, right? Same with a tube, right? If you get the tube in and then you start manipulating the airway, if you've not gone in far enough, the tube can slip out and you can get a displaced tube. So, many times you'll put the bougie in all the way down to the bifurcation.
It looked like he went right mains.
Yeah. And he did say into the lung tissue, right? Which would make most anesthesiologists gasp for air.
Well, it's actually a critical failure in innovation if your tube goes past the tip of your tube. So I don't see how stuffing a bougie right main stem is not a critical failure if you could actually do damage to the lung.
Because it's plastic and no shoot.
I'm just saying.
It depends on, so the answer is it depends on the type of bougie you have, right? So there are several different types of bougies, right? There are gum elastic bougies, which are very flexible, okay, and don't have much rigidity in them at all, okay? And generally those have a hollow tract even through the middle of them that you can actually bag a patient through. Yep. So there are those types of bougies. There are also more rigid bougies. We have a fairly rigid bougie, right? So if you were to sink that bougie down into the right main bronchus, you do have the risk of potentially tearing some tissue down there. And with stylet placement, I'm not a huge fan of stylets anymore, mostly because I think bougies are better for me personally, but there's also a very significant risk of tearing the trachea with a stylet because it is, like you talked about, a critical failure for your stylet to go beyond the tip of the tube. But many people still put the stylet down far enough for it to come out the side of the Murphy eye. And what happens is about 1 in 100 intubations in OR done by anesthesiologists or CRNAs. We don't have much data for EMS, okay? But we can suspect that it's probably at least as high as people that tube people every day for a living. It's about 1 in 1,000 patients with a stylet used have a torn trachea at the end of it. And that's even with the technique of just putting the tip of the tube in, then pulling the stylet, then advancing your ET tube farther down, okay? And classically in EMS, we're in a hurry, so we push the tube down a little bit farther with the stylet still in place, which is pretty hard on a trachea, especially a trachea that's maybe had radiation or some other type of issue going on, a 95-year-old trachea, for example.
Or somebody bleeding out of their trachea and esophagus.
Yeah.
It's 100,000 tubes compared to my 100. I'll make it this.
So, I tore somebody's trachea in the first year of being a paramedic myself, but it was with a combi tube, right? Combi tube's really stiff. And I was thinking that it was going in the esophagus and not in the trachea, and I tore the guy's trachea. He survived, but it was a bad look when his whole face blew up like a mushroom. Yeah, pretty sad. So, all right, we'll keep cracking on here. So we've got pulses back. Great. We saw the end tidal CO2, like Stormy said, rise up to 40. And now we're back into a normal range here. We got 35, 37, 44. Our perfusion is looking really great. Like Ken said, this person had a ROSC for a significant period of time, about 15, 20 minutes when they were loading up and getting ready to go to the hospital, right? We've got push dose epi drawn up because we can't get a blood pressure back. We've given 20 mics of push dose epi. So we're doing the right thing here, okay? We've got another 20 mics of push dose epi a few minutes later because we still can't get a blood pressure back. Tube placement was confirmed by Ken after the move, I believe. Yep. And from what you were talking about when we were discussing this is that her airway was completely soiled again with,
Yeah, she soaked.
with
through,
blood.
like, 3 towels, because we had her head kind of like this, because it was just pumping out. And she soaked through like 3 towels, the bed sheet and the green sheet, and then all onto the stretcher. It was a lot of blood.
Yeah.
And then we suctioned out a ton, like, I bet if we combined the 2 suction, it would have filled it up.
Yeah. So I'm gonna give you guys an idea. Whether you use it or not is totally up to you. I had a job very similar to this, except it was a patient that was still alive, okay? And she had a lot of blood coming out of her esophagus. What I did to help that situation was I got a 9.0 tube. I put it down the esophagus about halfway, and then I blew up the cuff and locked off the esophagus essentially. Many times what they'll use is an esophageal tube themselves. They make esophageal tubes for Mallory Weiss tears and for esophageal varices, where they'll actually put a very soft air balloon down into the esophagus to blow that up, provide pressure against whatever source of bleeding is occurring. We can do that pre-hospitally with a very large ET tube, and by filling up the cuff pressure of that ET tube to what we would usually use for tracheal tube.
I gotta throw a little bit of challenge to that. What if I see that being a pretty big risk of accidentally hooking the bin up to it, thinking you're on the right tube, choosing the wrong tube. That would be catastrophic to get that much air down there with all that blood also.
So it's important to remember that if you do place a large tube into the esophagus to blow the balloon up, you clamp off the top of the tube, because otherwise now all the blood is just going to race right up out of your tube.
So, and we don't carry the clamps either.
Yeah. We do carry clamps though in your OB kits,
Yeah.
which is what I used in my circumstance to lock off. Yes.
Did you do that before or after too?
And then eventually what I did was I used that ET tube as a tract to put my OG NG tube down into the stomach and decompress the stomach. Right? And I cannot take credit for this technique. All right? This was a technique I saw used by a FASM doctor with 25 years of experience to get an esophageal tube past a bleeding varices, right? When we did not have the correct device, which is an actual esophageal balloon, right? And it worked really well. It worked really well. What eventually happened was we had somehow gotten the tube placement correct, and the balloon blew up right over the bleeding varices, tamponaded that varices off just enough to slow the bleeding down. So we didn't have a great deal of return of blood in the upper airway, and we didn't have a great deal of blood going down into the stomach because we had it hooked up to low suction the entire time. Initially, we got tons of blood and tons of gastric contents out through the OG tube, and then that went to a very slow trickle, and the patient ended up surviving. What was likely an unsurvivable incident, because we were 4 hours away flight time from a tertiary facility that could go in and repair that surgically, right? So it is a technique. I'll run it past Bertus first to make sure that it makes sense to him. Like Stan said, there are some significant risk concerns there. And so it's a technique that I just want to share because I've seen it used successfully, but it's not necessarily something that I would expect anybody to adopt, right? It's an interesting technique. If you see it, the opportunity for it is this pretty much this case exactly.
Well, this would be a great last ditch effort, right? Like you're doing everything you can. You have to stop a bleed somehow. This is a great idea. Do something.
Yeah. In your patient that's alive, it's much more risky, right? Because if you're putting anything down the esophagus, you could worsen that varices a ton, and they could bleed to death rapidly through that. But at the same time, if your patient's already in cardiac arrest, okay, you don't have much to lose here. Or if your patient has, slowly gone downhill over the course of your treatment. I mean, let's say this patient was in Castleford instead, right? And was alive when you got to them and then went into cardiac arrest shortly after. They're bleeding to death and we have no way of controlling that if the bleed's coming from their esophagus, except for potentially direct pressure, which you could also utilize. Okay, you could literally just put your hand on top of the neck and do the burp procedure and squash the esophagus down. Okay, that also helps in these types of scenarios, classically the Selleck's maneuver. But what you're trying to do instead of closing off the esophagus so you don't get gastric contents coming back is you're just trying to tampen out the bleeding in the esophagus a little bit. So there are a few things that you can consider.
Was this one determined, did she actually have a varices? Because if it was pretty low, wasn't it?
We'll have a look at that in just a minute. I'll look at that in just a minute. So unfortunately for this patient, despite our best efforts and really great treatment here, we've got more fluid going in. We've got push dose epi going in. We still can't get a blood pressure back. And shortly after transport, we're back into a cardiac arrest.
It's driving faster.
Okay. We continued working the patient to hospital.
Eastland sucks, by the way, still. It's a new road, but it's still bumpy as hell as it was before.
Why?
It's like, because the city did it.
It's concrete.
Because the city did it.
I went that way thinking it was gonna be a smooth right in, but it wasn't.
Yeah. So we've got a few more rounds of epi for this patient. The patient's still in a PEA arrest, right? We're pausing, we're checking, patient's in PEA the entire time here, okay? We're still getting good end titles though, okay, which is still a really good indicator that this is just a hypovolemic arrest, all right? We still probably have some perfusion happening underneath the CPR and or she's filling up enough with CPR to get us really good kind of CO2 return. Right. So this 49-year-old female, this is the hospital course. Patient's been experiencing what sounded like GI bleeding for several days prior to cardiac arrest at home. Family reported that she was dizzy, lightheaded, had trouble mobilizing, and she was found deceased by the family who started CPR. Time frame that the patient was down was a little bit unclear, but we've pretty much cleared it up, I think, for us, that it was probably maybe 10 or 15 minutes at the very most, but she was probably in a low flow state more than anything. By standard CPR, she was brought to the hospital, obviously by ourselves. She lost pulses again in the ER. So they got her back in the ER again. She went into cardiac arrest again in the ER. They put the patient on pressors. And I'm guessing probably gave, yeah, there it is, received multiple blood product. Okay, so they replaced like for like here, which is what, at some point, maybe what we can do in the field. Patient was admitted to intensive care, so she made it out of the emergency department, right? Which is pretty amazing. Consultation with telemetry ICU. The patient continued to deteriorate despite maximum support. Ultimately, the family opted to begin comfort care and then withdrew the care, right? Per family wishes, comfort care measures were initiated and the patient passed away at 06:50. So about 5 hours after we brought her in. Right, so she survived for 5 additional hours. If this patient had had a survivable GI bleed, that 5 hours of time probably would have been enough to correct it. So great job. Really, when I look at it, like this is a really successful cardiac arrest on our end. We did everything we could for the patient. We did everything right in my mind. And so this patient had end-stage liver failure, right? This patient had an esophageal varices, and she also had an occult bleed in the stomach as well. So she had a gastric bleed as well. She had multiple sites of bleeding. So let's talk a little bit about cirrhosis before we end up today. So about 500,000 people in the US have cirrhosis of the liver, right? It's got a lot of different causes, but heavy alcohol use and hepatitis are among the leading causes, right? We're seeing that demographic change a little bit now with fatty liver disease, right? Fatty liver disease is becoming a real problem in the US, and it's leading to cirrhosis of the liver in many cases. That was came from pregnancy. So what happens when you have cirrhosis? We know that our liver detoxifies an enormous amount of blood in our body every minute. Okay, we've got a ton of blood going back through our liver. And what you have is you have a vein going back into your liver called the portal vein, right? And as the liver becomes engorged because it cannot process that amount of blood detoxification anymore, you get portal hypertension. So you get a backup of blood, much like we talked about yesterday in the interviews with congestive heart failure. The blood has to go somewhere, right? And so what happens is the entire system of the venous system inside of your body also gets engorged, right? Which is why we get esophageal varices, right? We've got a buildup of blood pressure throughout the body here. And specifically for alcoholics, it many times occurs in the esophageal veins. And because of that, you get esophageal varices. And esophageal varices are very common causes of death in end-stage liver failure for patients, all right? So a lot of different causes of a GI bleed. Let's go over a few of them here before we wrap up. So portal vein thromboses, right? So very common to get a large clot in your portal vein as well because you have stagnant blood there. It's not moving through the liver very well. One of my good friends in Santa Barbara when I lived in California, he was an older guy, super cool guy, always threw big house parties, right? Was a magnificent collector of alcoholic beverages. You could call him an alcoholic, I would say, in many cases. He had a very large portal vein thromboses, and it almost killed him. And then he had to sell his massive collection of wine because he stopped drinking. Cirrhosis is obviously that scarring of the liver, okay, can lead to portal vein hypertension. IVC obstruction leading to heart failure. So you get the backup of blood into the esophageal veins. It dilates them. It even tortures them, according to the sheet here. So those varices can rupture, and then you get really kind of aggressive bleeding a lot of different times, right? Farther down the tract, right? So now into the stomach, we've got H. pylori, which we talked about before, is that bacteria that can attack your stomach lining, can cause ulcerations. Non-steroidal anti-inflammatory drugs like ibuprofen can cause perforation and gastric ulcers in many people. Stress-induced. This is many people that you're looking for autoimmune diseases, right? Many of these are stress factors, Crohn's disease, for example. So we've got less protection of the stomach lining. We burn through the mucus lining, which then gets into the blood flow, the capillary beds, right? And then we get a bleed. You get a peptic ulcer. Okay, peptic ulcers can be very small. Some patients can have several of them, and they sometimes can be very large. And if they happen to erode into a large blood vessel, you can have catastrophic bleeding. And in this case, we had a patient with esophageal varices, and she had significant gastric ulceration as well, right? Excessive eating or excessive vomiting, sorry. So this is your classic Mallory-Weiss tear. So if you have a really explosive episode of vomiting, what happens is our esophagus is not capable of stretching out to facilitate all of that. Vomit is coming back up from the stomach, and you get a tear along the bottom of the esophagus going up vertically, and it's a very difficult tear to surgically correct. There's a lot of different grades of Mallory Rice tears. There's minor ones, there's moderate, and then there's really major kind of life-threatening Mallory Rice tears, but some of our patients will have those. And it all leads to bleeding into the stomach, right? That blood passes through the GI tract, becomes oxidized and digested, and you end up with melena. Sometimes the amount of blood irritates the stomach enough to end up with vomiting, and we get the coffee ground emesis. Sometimes that bleeding into the esophagus or from the esophagus or stomach is so much that we end up with hematemesis, which is that bright red blood. Okay. This is really the upper GI bleed specifically. We're not talking about the lower GI tract here at this point, because all of our patients that we talked about, although the second one may have had multiple sites of bleeding, were really suspected upper GI bleeds. There's a lot of different causes of lower GI bleeding that we're not going to discuss today. And then finally, a real quick review on liver cirrhosis. Okay. In this case, we knew what our liver cirrhosis was being caused by. It was being caused by, alcohol consumption. But liver cirrhosis can often lead to other types of problems. Many times you'll see ascites, which is that really bulbous abdomen with lots of, movable fluid inside of it. So when you palpate the abdomen, you almost get this wave-like effect to it. It's really interesting looking on ultrasound. Hepatic encephalopathy. We had a case review recently where we had a patient with hepatic and also alcohol probably derived encephalopathy. It was that gentleman that was unconscious in Kimberly that they ended up RSIing. Cardiomyopathy can also be affected by cirrhosis. So again, that's about that buildup in pressure in the liver. Carcinomas, portal hypertension is the most common cause of that gastric bleeding that we're going to see, right? It dilates all those veins. You get the varices, you get hemorrhoids, you get a lot of other downstream effects from portal hypertension. Bacterial causes, pulmonary complications from cirrhosis, and also kidney complications from cirrhosis. All right, any questions, any comments? Open it back up to the room for comments. Anybody had a GI bleed recently that they thought was interesting? Yeah, you just went over it. Yeah. Hannah, Max, James?
I wish Garrett was on because I thought he did really well. Good team lead, kind of stepped out of the box a little bit there. So did really well with the tube and just overall patient care. I thought he kicked ass.
Yeah, that's great to hear. Yeah. So when you see Garrett, give him a high five, give him a handshake, whatever you want to do. Tell him good job. I don't think we tell each other good job enough. Right? Maybe we do, maybe we don't. I don't know. But it's always nice to hear one of your peers give you some props for doing a great job on a patient. Obviously this last patient died in the end, but like I said before, if it was correctable, I think we probably would have been able to correct it. And because she was in a low flow state, you never know. This is somebody who might end up coming out of hospital at some point, right? It's unlikely, but if you're going to give them a chance, give them a chance. Right. That's it. Thank everybody online. Anybody online have anything to say? Anybody have a good case recently they want to just share? That's it. All right, guys, have a great day. Happy Halloween. Stay safe. Thank you. It's gonna get silly out there.
Thank you.
Love you, miss you, bye.
You're the one that chose to do it.
No, I can see that.
Yeah.
Yep. Yep.
Thank you very much.
Tomorrow.